Hello everyone. As a clinical pharmacology lecturer with a passion for cardiology, I'm thrilled to dive into the vital roles of a cardiology clinical pharmacist in a bustling 2,000-bed hospital. Whether you're a cardiologist, professor, or fellow pharmacist at an international conference, let's explore these 30 key activities in depth. Activity 1 entails participating in multidisciplinary bedside rounds on the CICU or CCU. Picture this, you're in the cardiac ICU, surrounded by intensivists, nurses, and fellows. As the pharmacist, I step in during rounds to flag potential drug interactions. For instance, a patient on amiodarone and warfarin, watch that INR spike. I suggest dose adjustments based on real-time labs. It's all about preventing adverse events right at the bedside. Think of it as being the pharmacotherapy guardian. In ACS cases, I ensure timely antiplatelet loading. Collaboration like this reduces errors by 30%. We discuss electrolytes hourly for arrhythmia risks. It's dynamic. My input shapes the plan instantly. For heart failure flares, I optimize GDMT titration. This role demands quick thinking under pressure. In a large hospital, rounds cover 20 to 30 patients daily. I bring evidence from ESC or AHA guidelines to the table. It's not just advice, it's integrated care. Pharmacists here cut readmissions significantly. Let's say a beta blocker switch is needed. I explain the rationale conversationally. This fosters team trust. In critical moments, my pharmacokinetic knowledge shines. For example, adjusting vancomycin in renal impairment during therapy of endocarditis. It's rewarding when outcomes improve. Rounds are the heartbeat of our work, literally. Activity 2, daily prospective review and optimization of medication regimens for acute coronary syndromes. In ACS management, every minute counts. I review STEMI patients post-thrombolysis or PCI. Optimizing aspirin and P2Y12 inhibitors like ticagrelor is key. I check for bleeding risks, especially in elderly folks. Dose adjustments for renal function, crucial with eGFR below 30. We aim for guideline-directed therapy from AHA-ACC. I flag contraindications, like avoiding NSAIDs. In unstable angina, I ensure beta blockers are titrated safely. This prospective approach prevents downstream complications. Think of it as proactive pharmacovigilance. In a large center, I handle dozens of cases daily. I use tools like CHADS2 VASC for concurrent AFib. Optimization includes lipid control from day one. It's about holistic regimens. For NSTEMI, I push for early invasive strategies with antithrombotics. Evidence shows this cuts mortality. I educate the team on agents like prasugrel. It's conversational. Hey, let's switch to clopidogrel if there are CYP2C19 issues. This builds efficacy. In high-volume settings, automation helps. But human insight is irreplaceable. Outcomes, better adherence and fewer NACE events. Plato and Triton TIMI trials back aggressive antiplatelet use. In our center, it shortens length of stay. I document every recommendation. The team appreciates the clarity. Activity 3 entails individualizing anticoagulation therapy. An AFib patient arrives. CHA 2DS2 VAS score 4. Anticoagulation is an art and science. For AFib patients, I tailor DOACs like apixaban based on creatinine clearance and weight. DOAC are first line. Apixaban 5 mg twice daily orally is the usual dose. But weight over 120 kg? Still fine. For creatinine clearance 25 to 50, reduced to 2.5 mg twice daily. Warfarin? I manage INRs meticulously, aiming 2 to 3 for most. Warfarin for mechanical mitral valve. Target INR 2.5 to 3.5. I bridge carefully peri-procedure. LMWH until INR is therapeutic. LV thrombus post-MI, direct oral or vitamin K antagonists. I weigh risks. Warfarin or DOAC, debate ongoing. I monitor for bleeds using has-bled scores. Has-bled guides bleed risk. High risk, discuss with cardiology. Reversal agents should be ready. Andexanet for apixaban, PCC for warfarin. I counsel every patient, take with food for rivaroxaban. Compliance skyrockets. This slashes stroke risk by over 60%. Personalization is everything. In a transplant center, interactions with immunosuppressants are tricky. Evidence from RELI and Rocket AF guides me. For VTE in cardiology, duration matters. I ensure compliance with apps or clinics. In critical care, we use parenteral options like argatroban for HIT. I discuss with cardiologists daily. Think of it as balancing clot and bleed. In academics, I teach on pharmacogenomics for warfarin. Outcomes soar with individualization. Activity 4 entails adjusting heart failure pharmacotherapy. Heart failure optimization is transformative. Half-ref patient, ejection fraction 25%. Start ARNI if tolerated. Titrate slowly to avoid hypotension. For sacubitril valsartan, start 24/26 mg twice daily. Titrate up every 2 to 4 weeks. Watch BP and potassium. For beta blockers, we use carvedilol or bisoprolol, up to target doses. Dose carvedilol at 3.125 mg twice daily. Target 25 mg twice daily. MRAs like spironolactone are also used. Monitor potassium closely. Dose spironolactone at 25 mg daily. And remember to check potassium in 1 week. SGLT2 inhibitors, empagliflozin shines for half ref and half PEF. Dose dapagliflozin 10 mg daily. This reduces hospitalizations dramatically. The DAPA-HF and EMPEROR-Reduce trials prove it. Use loop diuretics for volume overload but minimize dose. For congestion, administer furosemide IV initially. Use ivabradine for sinus rhythm if HR over 70 on maximum beta blocker. GDMT protocols from ESC drive this. GDMT optimization cuts mortality 50 to 60%. In decompensated states, I adjust for AKI. Evidence from Paradigm HF is gold standard. I track BNP trends for efficacy. It's stepwise. Start low, go slow. In advanced HF, add vericiguat if needed. This cuts hospitalizations by 20 to 30%. I monitor response daily. Weight, JVP, BNP trends. I collaborate on outpatient transitions. Pharmacists ensure affordability too. Think conversational. Let's bump that Entresto dose if BP allows. Outcomes, improved ejection fractions and quality of life. Stepwise, evidence-driven. Patients feel the difference. Activity 5 entails providing pharmacotherapy recommendations post-PCI or CABG. Post-procedure care is critical. Post-PCI involving use of drug-eluting stent, dual antiplatelet therapy is mandatory. Some clinicians use aspirin and clopidogrel for a duration of 6 to 12 months based on stent type. Others use aspirin plus ticagrelor, 12 months minimum. In case of complex PCI, clinicians extend to 3 years sometimes. Bleeding risk high, shortened to 1 to 3 months. Post-CABG, continue aspirin indefinitely. Add high-intensity statin. I recommend atorvastatin 80 mg for secondary prevention. Rosuvastatin 40 mg daily is an alternative. If AFib develops post-operatively, add anticoagulation. Monitor for graft thrombosis. Guidelines from ACC stress this. I adjust for drug allergies. In diabetics, optimize with ticagrelor. It's about preventing restenosis. Evidence from Plato trial informs. I counsel on adherence, the key to success. In large centers, protocols standardize this. Think, extend dual antiplatelet therapy if complex PCI. This reduces ischemic events. Pharmacists track follow-up labs. Outcomes include fewer readmits. I review discharge meds thoroughly. Take ticagrelor twice daily, no skipping. Adherence prevents stent thrombosis. ACC guidelines drive this. Outcomes improve markedly. Activity 6 entails monitoring and advising on anti-arrhythmic drug therapy. Anti-arrhythmics demand vigilance. Amiodarone loading for VT, watch thyroid and lungs. Ensure amiodarone for refractory AFib. The loading dose is 200 mg thrice daily for weeks, then maintenance 200 mg daily. I order baseline TSH, LFTs, and a chest X-ray. Repeat every 6 months. Using sotalol, strict QT monitoring is essential. Hold if QTC is greater than 500 milliseconds. Dofetilide initiation is done in hospital with telemetry for 3 days. I adjust for electrolytes, especially calcium and magnesium. I advise on interactions. Avoid QT prolongers. In electrophysiology labs, I ensure safe use. Guidelines from AHA guide dosing. For AFib rate control, beta blockers first. I flag interactions like with digoxin. Evidence from CAST trial warns of pro-arrhythmia. It's personalized based on rhythm. In ICU, IV options prevail. Think, check that QTC before next dose. This prevents torsade de pour. Pharmacists lead protocols here. Outcomes, stable rhythms, and fewer shocks. Activity 7 entails managing lipid-lowering therapy in secondary prevention. Lipids are frontline in prevention. High-intensity statins like rosuvastatin 40 mg target LDL below 55 mg per deciliter. Add ezetimibe if not at goal. Dose it at 10 mg daily. Still high? Use PCSK9 inhibitors like evolocumab for familial hypercholesterolemia. Use bempedoic acid for statin-intolerant cases. Use inclisiran injections for long-term control. Inclisiran twice yearly is a game changer. ESC guidelines push aggressive targets. I monitor CK, LFTs, and myalgias. Myalgias are common, switch agents if they are overwhelming. Post-ACS, start day 1. Evidence from FOURIER and ODYSSEY trials shows CV risk reduction. Aggressive control stabilizes plaque. Patients live longer. It's stepwise escalation. Think, let's add alirocumab if LDL persists. This halves MACE risks. In academics, I research adherence barriers. Outcomes, plaque stabilization. Activity 8 entails performing medication reconciliation on admission and discharge. Medication reconciliation is error prevention 101. On admission, patient list can have up to 12 meds. On admission, verify home meds against history. Discrepancies, common in polypharmacy. A common scenario is omitted beta blocker. I verify against GP records, bottles, history. I reconcile within 24 hours. At discharge, ensure continuity, ensuring there are no omissions. In cardiology, antithrombotics are high risk. I use electronic tools for accuracy. Guidelines from Joint Commission mandate this. Evidence shows 50% error reduction. It's thorough, cross-check allergies too. Think, patient says aspirin, but chart misses it. This averts adverse events. In large hospitals, pharmacists lead this. Outcomes, safer transitions. Activity 9 entails conducting patient counseling on complex regimens. Counseling empowers patients. Explain DOAC timing. Take rivaroxaban with food. Side effects, watch for bruising. Adherence tools like pill boxes. Sick day rules for HF. Hold SGLT2 if dehydrated. In anticoagulation, diet for warfarin. Ensure consistent vitamin K intake. Apixaban, twice daily, same time. Evidence from studies shows counseling halves non-adherence, resulting in better compliance. Patients leave confident. It's empathetic and clear. Questions? I'm here. In clinics, face-to-face works best. Outcomes? Lower non-adherence rates. Activity 10 entails leading anticoagulation stewardship and peri-procedural bridging. Anticoagulation stewardship entails keeping it safe and smart. We have hospital-wide protocols, but I lead cardiology-specific tweaks. Bridging high thrombotic cases such as mechanical valve or recent stent placement, bridge with LMWH or UFH. Low-risk cases such as AFib CHADS to low, no bridge. Just hold DOAC 24 to 48 hours pre-procedure. I audit monthly. Overbridging causes bleeds, underbridging causes clots. Reversal pathways are crystal clear. Idarucizumab for dabigatran, andexanet alpha for 10A inhibitors, and PCC for warfarin. Pericath lab bivalirudin preferred in HIT cases. I educate fellows. For this TAVR patient, hold apixaban 48 hours, no bridge. ASP and ACC guidelines anchor our work. Stewardship reduces unnecessary exposure, cuts costs, lowers complications. In a busy hospital, this prevents a lot of weekend emergencies. Activity 11 entails responding to code blue or medical emergencies. Code blue, heart stops, room fills fast. In codes, pharmacists are vital. I grab the crash cart drugs, stand by the leader. Shock, vasopressor time, noradrenaline first line for cardiogenic shock. Start at 0.05 micrograms per kilogram per minute, titrate to MAP 65. VT storm, amiodarone 150 milligrams IV over 10 minutes, then infusion. Massive PE, alteplase if unstable, weigh risks in recent surgery. Anaphylaxis or HIT, argatroban ready. Reversal in bleed, prothrombin complex concentrate for warfarin. ECLS algorithms guide, but I adjust for renal function, weight, or interactions. Pharmacist in the room improves time to drug and survival odds. Postcode I review. Why did we choose dobutamine over milrinone here? It's high pressure but rewarding, direct, life-saving input. Activity 12 entails managing pharmacotherapy in advanced heart failure, advanced HF, stage D, low output, recurrent admissions. Inotropes become necessary. Milrinone, a phosphodiesterase inhibitor, good for high pulmonary pressures. Start 0.375 micrograms per kilogram per minute, titrate to cardiac index above 2.2. This bridges to transplant. Outcomes: stabilized hemodynamics. Watch BP, it vasodilates, so is noradrenaline, often co-infused. Dobutamine, a beta agonist, is a cheaper alternative but more arrhythmogenic. I monitor daily lactate, the CVO2, and urine output. Pulmonary vasodilators, sildenafil for RV failure, inhaled nitric oxide in ICU. Pre-LVAD or transplant optimize volume, inotropes, optimize GDMT as much as possible first. Use vericiguat if there are persistent symptoms on quad therapy. ISHLT guidelines steer us. Bridge therapy buys time, weeks to months. When it works, patient stabilizes, gets to surgery. It's intense, but seeing someone walk out after months in ICU, that's why we do it. Activity 13 entails reviewing therapy in cardiac transplant patients. Cardiac transplant. It's a whole new world post-op. Patients out of ICU, now on the ward. Tacrolimus, mycophenolate, prednisolone standard triple therapy. Post-transplant, tacrolimus levels are key. Adjust for interactions. I check tacrolimus levels daily early on. Target 8 to 12 nanograms per milliliter, first 3 months per ISHLT 2023 guidelines. It is still the cornerstone in 2026, with 2025 updates reinforcing rejection surveillance. TAX 14 today, reduced dose 0.5 milligrams twice daily, recheck tomorrow. Mycophenolate, watch for GI upset or leukopenia. GI side effects are common. Switch to enteric-coated if diarrhea persists. Use sirolimus or everolimus for renal sparing in chronic kidney disease cases. Belatacept is emerging as alternative in some protocols. Interactions everywhere. Statins with tacrolimus bump levels, azoles push tax sky high. I review CMV prophylaxis, valganciclovir standard for high risk. Regarding rejection surveillance, endomyocardial biopsies guide us, but I flag rising BNP or new arrhythmias. Long-term minimize steroids to avoid diabetes mellitus and osteoporosis. Cardiac allograft vasculopathy, aggressive lipids, everolimus helps slow it. In our center, pharmacist input on immunosuppression cuts rejection episodes and hospital days. It's meticulous, daily tweaks save grafts and lives. Activity 14 entails participating in outpatient cardiology clinics. Outpatient clinics, extending the inpatient magic. In clinics, collaborative agreements allow dosing. Heart failure clinic twice weekly, I join under collaborative practice agreements. Still growing in many systems, physician-led, pharmacist-enabled models per recent consensus papers. Patient with half-ref EF 35%, on max GDMT but still NYHA2. I review labs, creatinine stable, potassium 4.6. Safe to up Entresto to 97/103 milligrams twice daily. SGLT2 inhibitor already on board, empagliflozin or dapagliflozin, confirmed adherence. Anticoagulation clinic arm, INR checks. DOAC dose tweaks for weight or renal changes. Post-ACS follow-up, lipid panel review, ensure high-intensity statin plus ezetimibe if needed. Patient education on the spot, sick day rules for your SGLT2 inhibitor hold if dehydrated. Evidence shows pharmacist-led titration improves GDMT achievement rates to 80 to 90%. Better control, fewer readmissions, better quality of life. Post-ACS lipid check is critical. Think up that beta blocker. This extends inpatient care. Outcomes, reduced visits. It's collaborative. Cardiologist signs off protocols. I handle the fine-tuning. Patients appreciate the continuity. No waiting for the next doc visit. Activity 15 entails developing institution-specific guidelines. Guidelines aren't static. We build our own. ACS pathway, incorporate 2025 ACC AHA ACS updates. Immediate high-intensity statin plus ezetimibe option in hospital. Heart failure order set. ARNI first line. SGLT2 inhibitors universal. finerenone emerging for half PEF or half MREF per 2025 approvals and FINATS HF data. This standardizes care. Outcomes, consistency. Regarding anticoagulation reversal, andexanet alpha pathways were updated. At committee level, review new agents like mavacamten for HCM. Evidence review. ESC 2025 dyslipidemia update pushes LDL below 55 even harder. Add to our secondary prevention bundle. Order sets standardized care across large hospitals, which reduces variation. Annual audits ensure alignment with ESC, AHA, and ISHLT. It's behind-the-scenes work, but it shapes every patient's regimen. Activity 16 entails leading antimicrobial stewardship for endocarditis. Let's talk about leading antimicrobial stewardship for endocarditis. It's a big deal in medicine. Infective endocarditis, or IE, is a serious heart valve infection. It can be life-threatening if not handled right. Stewardship means using antibiotics smartly to fight resistance and improve outcomes. For IE, we often start with vancomycin. Dosing it based on AUC is key. AUC stands for area under the curve. It measures drug exposure over time. Target for vancomycin in Staphylococcus aureus on native valves, 400 to 600. That ensures enough drug to kill the bacteria. Remember the old trough target? 15 to 20 micrograms per milliliter. But AUC is more precise now. Aminoglycosides like gentamicin add synergy. They team up with other antibiotics. For Enterococcus IE, we recommend pairing ampicillin with gentamicin. Use a short course if the bug is sensitive. Short course means less time on gentamicin, reduces kidney risks. Daily culture reviews are crucial. Check MIC levels, minimum inhibitory concentration. If MIC is low, de-escalate. Maybe switch to ampicillin alone after weeks. Prosthetic valves change the game. Add rifampicin for staph infections. Longer treatment duration here to cover biofilms on artificial parts. Monitor resistance patterns always. Our center sees rising VRE, vancomycin-resistant enterococci. VRE is tough. Adjust therapies based on local data. IDSA guidelines are the gold standard from the Infectious Diseases Society of America. ESC guidelines from Europe too. They anchor our approach. But adapt to your hospital's antibiogram. That's the local resistance snapshot. Audits on treatment duration help prevent overuse of antibiotics. Overuse leads to C. diff infections, nasty gut issues. Pharmacists play a huge role in stewardship. They spot inappropriate prolonged therapy. Cut that down, leads to better cure rates. Fewer complications overall, like less resistance or side effects. Evidence shows this works. Shorter targeted therapy reduces hospital stays. Think target trough 15 to 20, but evolve to AUC for vancomycin. This stewardship cures infections, improves patient outcomes. Cure rates rise with smart monitoring. Resistance gets managed. In the end, it's about balance. Potent treatment without excess. That's leading stewardship for endocarditis. High stakes, but rewarding. Activity 17 entails monitoring for drug-induced QT prolongation. It's a sneaky risk on the wards. QT prolongation can result in Torsades de Poor. TDP is a dangerous twisting ventricular tachycardia. It causes sudden cardiac arrest if unchecked. Amiodarone is a classic culprit. It prolongs QT almost always. But Torsades from amiodarone alone? Rare. Still, we watch closely. We do a baseline ECG before starting. That's non-negotiable. Measure QTC accurately. Corrected for heart rate. Add risky combos? Big trouble. Amiodarone plus haloperidol for delirium? Hold off. QTC jumps fast. From 460 to 510 milliseconds, that's Torsades territory. Sotalol and dofetilide demand strict eyes. They carry higher TDP risk. Guidelines from AHA and ESC warn clearly. Prevent TDP at all costs. Key rule, QTC over 500 milliseconds? Hold the agent immediately, or if it rises more than 60 milliseconds from baseline. Stop and reassess. Daily ECGs in high-risk spots, especially ICU patients, on multiple QT prolongers. Flag dangerous pairs, ondansetron, macrolides, antipsychotics. They stack the risk. Correct electrolytes every time. Potassium above 4, magnesium above 2, always. Hypokalemia or low mag, they amplify prolongation. Fix them fast. My vigilance catches issues early. I review ECGs daily, spot rising QTC, intervene before arrhythmia hits. This prevents arrests, saves lives, safer therapy overall, better outcomes, fewer complications. Think QTC over 500? Hold. Simple, life-saving. That's monitoring for drug-induced QT prolongation. Stay sharp, it matters. Activity 18 entails providing pharmacokinetic consultations. This is where we get precise with drugs, especially the tricky ones, narrow therapeutic index drugs. They demand careful dosing. Digoxin in heart failure is a classic. We target serum levels of 0.5 to 0.9 nanogram per milliliter, not the old 0.8 to 2.0. Lower range works best, controls symptoms, cuts hospitalizations, reduces toxicity risk. Toxicity hits hard. Nausea, confusion, arrhythmias, we avoid that. Renal function drives dosing. Kidneys clear digoxin slowly. Creatinine clearance drops, dose drops. Creatinine clearance around 30 milliliters per minute. Think, half dose if creatinine clearance is 30. Standard maintenance might be 0.125 milligram daily. Halve it to 0.0625 milligrams every other day, or even lower. Check level after steady state. Adjust again if needed. Patient example. Heart failure patient, digoxin level creeping to 1.2 nanograms per milliliter. Symptom control stays solid, toxicity fades. Vancomycin follows the same logic. In endocarditis, AUC 400 to 600 is gold, not just troughs anymore. I calculate creatinine clearance. Factor in weight, body size matters. Recommend loading dose, then maintenance, timing for levels, adjust fast. Tacrolimus post-transplant. Another narrow index star. Levels too high, nephrotoxicity. Too low, rejection. I review troughs, renal function, liver function, drug interactions, recommend tweaks. Theophylline? Rare now, but same principle. We catch issues early, prevent harm, boost efficacy. Consult save time, save kidneys, save lives. Pharmacokinetic consults matter. We optimize therapy, one patient at a time. That's the job. Precise, thoughtful, effective. Activity 19 entails conducting therapeutic drug monitoring. First, consider vancomycin, used in infective endocarditis or IE. We monitor its AUC over MIC ratio. AUC stands for area under the curve. MIC is minimum inhibitory concentration. Target range, 400 to 600. Why monitor? To ensure efficacy and avoid toxicity. Next, immunosuppressants. Think post-transplant patients. Drugs like tacrolimus and sirolimus. We check levels daily, adjust doses based on those readings. Labs are key, done every day in many cases. Remember the mantra, adjust based on peak or trough levels depending on the drug. Outcomes matter. We aim for therapeutic ranges, keeps patients safe and treated. TDM is our daily bread and butter, essential in clinical practice. For vancomycin in IE, use troughs or AUC. Troughs or pre-dose level. Tacrolimus, daily monitoring post-transplant. Same for sirolimus. Suspect digoxin toxicity? Check levels then. Aminoglycosides for synergy in endocarditis. Monitor to prevent harm. Timing is crucial. Labs precisely timed. Trough just before the next dose. Adjustments? Make them the same day. Keeps levels in range. This prevents under or overdosing. It improves patient outcomes. Think of it as fine-tuning, like adjusting a delicate instrument. In transplants, wrong levels, risk rejection or infection. For vancomycin, subtherapeutical, infection persists. Over, kidney issues arise. So TDM guides us. Daily vigilance pays off. That's the essence. Any questions? Activity 20 entails identifying and reporting adverse drug reactions. This is vital work. We stay vigilant every day. First example, bleeding on direct oral anticoagulants, DOACs, apixaban, rivaroxaban, dabigatran. A major bleed occurs. You see it, you act. Hold the drug, reverse if needed, then document clearly in the notes. Something like, major gastrointestinal bleed. Apixaban held, vitamin K and PCC given. Next step, report it promptly. In many places, we report to our National Pharmacovigilance System, yellow card in the UK, or to the FDA if you're stateside. Why bother? Because every report counts. Patterns emerge. One bleed might be chance. 10 bleeds on the same dose? That's a signal. Next one, hyperkalemia on an ACE inhibitor or on an MRA like spironolactone. Potassium climbs, patient becomes symptomatic, or the lab flags it. You document. Serum potassium 6.8 on spironolactone 25 milligrams, drug withheld. Potassium lowering therapy started. Then flag it. Tell the team. Perhaps suggest a protocol tweak. Maybe reduce the starting dose in high-risk patients or increase monitoring frequency. That's how systems improve. Think of the mantra here. Document and mitigate. Write it down accurately. Then take steps to reduce the risk. Outcomes? Safer prescribing. Fewer repeats of the same problem. Across the whole center. Across the country. Reporting isn't extra work. It's core to what we do. It protects the next patient and the one after that. So keep your eyes open. Spot the ADR, act fast, report it properly. That's how we make medicines safer. Together. Any thoughts on that one? Activity 21 entails precepting pharmacy students and residents. Teaching on rotations. That's where the real learning happens. A new student arrives. Day 1. We assign cases straight away. Acute coronary syndrome medication reconciliation. Heart failure dose titration. Practical, hands-on stuff. We head to the bedside together. Patient in front of us. Real medicines. Real decisions. I'll ask gently, why switch to clopidogrel here instead of ticagrelor? What's the target beta blocker dose in this systolic heart failure patient? They think, they reason, they explain. That's when the light comes on. Residents get a bit more rope. They lead rounds. I shadow quietly, ready to step in if needed. We run journal clubs too, fresh trials. Take Fine Arts HF involving finerenone in heart failure. What did it show? Who benefits most? How does it change our practice? I nudge them, apply guidelines here. That's the mantra. Don't just read the guideline. Use it on this patient today. Evidence-based thinking grows. Confidence builds. Slowly but surely. Outcomes? We're training the next generation. Future specialists. Pharmacists who question, who reason, who keep patients safer. It's not always easy. It takes time. It takes patience. But when you see that student spot a drug interaction you might have missed, or when a resident confidently defends a dose adjustment on rounds, that's pure joy. Precepting isn't extra. It's core. We pass the torch. One case, one question, one rotation at a time. Right, that's activity 21. Feels good, doesn't it? Activity 22 entails delivering formal teaching sessions. We teach fellows, we teach nurses, sometimes pharmacists too. Different audiences, same goal. Take cardiovascular pharmacology. That's my bread and butter. Lectures on DOACs are always popular. I stand up front, slides ready, but it's not a monologue. I start with the big trials. Aristotle for apixaban, Rely for dabigatran, Rocket AF for rivaroxaban. Then I pause. I ask the room, what did Aristotle show in the elderly subgroup? Hands go up, someone says reduced bleeding. Someone else mentions stroke prevention held up. Spot on. We use polls. Quick ones. Which DOAC has the lowest intracranial bleed rate in trials? Results flash up. Discussion follows. That's when learning sticks. Later, same week perhaps, nurses session. Anti-arrhythmics or practical warfarin bridging. I show a case. Elderly patient, AF, needs surgery. INR 2.8. What now? We talk vitamin K. We talk bridging with heparin. We talk timing. Real-world stuff they'll use tomorrow. Interactive again. Small groups. Quick cases. What would you do here? They talk. They argue a bit. They learn from each other. The mantra? Discuss DOAC trials. Or discuss pitfalls. Make it relevant. Make it stick. Outcomes, knowledge spreads. That's the point. Fellows prescribe more confidently. Nurses spot issues earlier. The whole team delivers better care. One lecture at a time. One question at a time. Knowledge ripples out. It's exhausting, yes, but rewarding immensely. Right, that's activity 22. Feels like we're building something important, doesn't it? Activity 23 entails leading quality improvement projects, QI on HF readmits, interventions like counseling, data-driven. Think GDMT at 90%. Outcomes, lower rates. HF readmissions target GDMT 90%. Pharmacist counseling bundle, cut non-adherence. Data tracked, results presented at grand rounds. We start with data, baseline readmission rate, baseline GDMT achievement, often disappointingly low. Then we design interventions, small tests first, PDSA cycles. One intervention, a structured GDMT titration protocol, stepwise increases, clear stopping rules. Pharmacist checks every step. Another, a pharmacist counseling bundle. Teach patients about each drug, why it matters, what side effects to watch, how to take it properly. We roll these out, track the data weekly, run charts, see the signals. Did GDMT hit 90%? Did readmissions drop? Numbers tell the story. When they do drop, and they usually do, we celebrate quietly. Then present at grand rounds. Show the before and after. Show the interventions. Show the lives potentially saved. Outcomes? Lower readmission rates. Better patient quality of life. Safer prescribing habits baked into the system. QI isn't glamorous. It's meetings. It's spreadsheets. It's persuading colleagues. But when you see that line on the chart trend downwards, when a ward team says, "We've changed how we do this now," that's when you know it's worth every minute. Data-driven, team effort, persistent tweaks, real change. That's activity 23, leading QI projects. Feels like moving the needle, doesn't it? Activity 24 entails participating in clinical research. We join studies on new agents, cutting-edge treatments, ones that might change practice. Take mavacamten as our example, a myosin inhibitor for obstructive hypertrophic cardiomyopathy. Game changer potential. We recruit patients. That's step one. Screen them carefully. Check inclusion criteria. No major exclusions. Explain the trial clearly. Risks, benefits, what's involved. Then obtain proper informed consent. Once enrolled, we monitor closely. Regular visits, echoes, bloods, symptoms. We collect data meticulously. Adherence to mavacamten. Plasma levels if required. Side effects logged. Pharmacotherapy endpoints matter to us. How well the drug is tolerated. Plasma levels if required. Side effects logged. Pharmacotherapy endpoints matter to us. How well the drug is tolerated. How consistently it's taken. Every patient we enroll helps, builds the evidence base. Outcomes, real advancements. New data published. Guidelines updated. Patients get better options sooner. It's not always smooth. Recruitment can be slow. Paperwork piles up. Monitoring takes time. But when you see the results come out, say, reduced outflow gradients, fewer symptoms, fewer procedures, that's why we do it. Think of the mantra, enroll in mavacamten trial, or whichever study is live. We contribute. One patient at a time, one data point at a time. That is how the field moves forward. Research isn't separate from clinical care. It's woven in. Feels rather inspiring, doesn't it? Activity 25 entails contributing to formulary management. We sit on the Pharmacy and Therapeutics Committee, P&T for short, deciding what drugs stay on the hospital list. Take the latest lipid-lowering agents, PCSK9 inhibitors, inclisiran, bempedoic acid. A review comes up. We dig in. First question. What's the evidence? Strong randomized trials? Clear patient benefit? Next, cost efficacy. How much bang for the buck? PCSK9 inhibitors for familial hypercholesterolemia, FH. They drop LDL dramatically. Cardiovascular events fall too. But the price tag? Eye-watering. We look at the numbers. number needed to treat, quality-adjusted life years, local budget impact. The mantra here, add if evidence is strong. Not just any evidence, robust, relevant to our patients. We present to the committee clear slides, balanced view. Inclisiran, twice yearly dosing, good adherence potential, but cost per quality high unless restricted criteria. Bempedoic acid is oral, fewer injections, statin-intolerant patients benefit. Add for that group? We debate, we vote. 2025 lipid guideline updates help, ESC or AHA recommendations. New data on outcomes. If the evidence holds and criteria make sense, we add it. With restrictions perhaps, prior authorization, specialist initiation. Outcomes? Optimal agents on formulary. Not the flashiest, not the cheapest, but the ones that truly help the right patients. No waste, no unnecessary spending, best care within resources. That's formulary management. Thoughtful, evidence-based, team effort. Keeps the formulary lean, keeps prescribing sensible. Feels rather responsible, doesn't it? Activity 26 entails developing restricted protocols. Take bivalirudin in the cath lab, a direct thrombin inhibitor. Very useful, but not for everyone. We restrict it. Why? Because it's expensive. And heparin usually does the job perfectly well. But there's one big exception, heparin-induced thrombocytopenia, HIT. In HIT, heparin is dangerous, can cause terrible thrombosis, so we need an alternative. Enter bivalirudin, preferred in many PCI cases when HIT is confirmed or strongly suspected. We write a clear protocol, criteria-based, no gray areas. Something like this. Approved only if documented HIT with positive serotonin release assay, or history of HIT antibody with recent exposure, or acute HIT during current admission. No maybe HIT approvals. Evidence required. The mantra, approve for HIT. Simple, strict, protects the patient. Once approved, the protocol guides dosing. Bolus, then infusion. Adjusted for renal function. Monitoring ACT in the lab. The pharmacist reviews every request, checks criteria, signs off or queries. Outcomes, safe, targeted use. Bivalirudin is given only when truly needed. Heparin stays the default. Waste is avoided. Thrombotic and bleeding risks are minimized. No cowboy prescribing, no accidental heparin in HIT patients. That's the beauty of a good restricted protocol. Clear rules, enforced fairly, everyone knows where they stand. Keeps the cath lab running smoothly, keeps patients safer. Feels rather reassuring, doesn't it? Activity 27 entails providing discharge planning support. Patients are leaving hospital, new prescriptions in hand. But many meds are expensive, very expensive. We step in early, bridge the gap. We make sure there's no break in therapy. First example, Entresto, sacubitril valsartan for heart failure. Pricey, often needs prior authorization. We sort the paperwork, submit the prior authorization, chase the approval, get it covered before discharge. Next, DOACs, apixaban, rivaroxaban, edoxaban, dabigatran. Cost can be a barrier at home. Many manufacturers run patient assistance programs, copay cards, free supply for eligible patients. We identify who qualifies, fill in the forms, link the patient to the program. The mantra here, ensure DOAC supply, or any high-cost med. Simple idea, powerful impact. We write bridge scripts, usually 30 days, sometimes 14 or 90, depending on the situation. Dispense 30-day supply of apixaban, 5 milligrams twice daily before discharge. Patient assistance application pending. Pharmacist checks insurance, checks eligibility, coordinates with social work if needed. Why 30 days? Gives breathing space. Time to sort long-term supply. Avoid that dreadful gap where the patient stops taking the drug. Outcomes, seamless care, no interruptions. No readmission because of non-adherence. No decompensation in heart failure. No stroke because a DOAC was missed. Patient leaves confident, family relieved. Team knows the plan is solid. It takes coordination, phone calls, emails, follow-ups. But when that patient returns for follow-up and says, "I've been taking it every day, no problem." Discharge planning isn't glamorous. It's essential. We close the loop. We protect the progress made in hospital. That's activity 27. Feels like the final piece of the puzzle, doesn't it? Activity 28 entails running pharmacist-led clinics. Take anticoagulant follow-up. Often virtual now. Saves everyone time. Still delivers brilliant care. Patient joins from home. We review the INR if they're on warfarin, or renal function if they're on a DOAC. We check adherence. Any bleeding? Any bruising? Missed doses? Then we tweak the dose if needed. Small adjustments. Warfarin perhaps up or down by 10 or 20%. For DOACs, we might switch timing, or hold briefly if creatinine's climbing. The mantra here? INR stable? Good. Simple. But it means everything. Stable INR means excellent time in therapeutic range. Fewer clots, fewer bleeds. We aim high. Time in range above 70%, ideally 80 or more. Virtual makes it easy. No travel, quick check-ins. Every 4 to 6 weeks for stable patients. We reinforce education too. Take a Pixaban with food if it upsets your stomach. Watch for dark stools on warfarin. Outcomes? Better management. Truly. Fewer hospital visits for INR instability. Fewer strokes. Fewer major bleeds. Patient feels supported, not just prescribed to, listened to. The clinic runs smoothly. Pharmacist autonomous. Protocol driven. Doctor available if tricky. It frees up cardiology time too. Win all round. That's activity 28, pharmacist-led anticoagulant clinics. Virtual or face-to-face. Doesn't matter. The impact does. Feels rather empowering, doesn't it? Activity 29 entails analyzing medication utilization data. We look at what we're actually prescribing, not what we think we're prescribing. Take SGLT2 inhibitors in heart failure. They're guideline gold. Reduce hospitalizations, reduce deaths. Yet sometimes our local data shows uptake is low, disappointingly low. First step, benchmark. Compare ourselves to the best. We pull the latest AHA or ESC figures. What percentage of eligible heart failure patients are on an SGLT2 inhibitor? Often 70–80% in top centers score. We check our own numbers. Say it's only 35%. Ouch. The mantra here? Increase SGLT2 use. Clear target, measurable, important. We dig deeper. Which wards lag? Which consultants prescribe least? Any barriers? Then we act. Education sessions, quick pocket guides, one-page protocols. Start empagliflozin or dapagliflozin day 2 of admission if EGFR allows. Pharmacists on rounds nudge gently. This patient qualifies. Shall we add it? We track monthly, run charts, show the upward trend at department meetings. Outcomes? Alignment, real alignment with guidelines. Higher GDMT rates, fewer readmissions, patients live longer, feel better. It's not finger pointing, it's gentle push, data-driven push. One audit, one benchmark, one education drive. Practice slowly shifts. That's how utilization analysis changes care. Quietly, steadily. Feels rather satisfying when the curve starts climbing, doesn't it? Finally, activity 30 entails collaborating on multi-center audits. Take Get with the Guidelines Heart Failure, GWTG-HF, American Heart Association Program, world-class quality registry. Hospitals across the country submit data, thousands of patients, real-world heart failure care. Pharmacists get involved. We don't just watch, we contribute. We feed in metrics, guideline-directed medical therapy, GDMT achievement rates, beta blockers at target dose, ACE inhibitor or ARNI, mineralocorticoid antagonists, SGLT2 inhibitors, the full quartet. The mantra here? Contribute metrics, Simple, precise, powerful. We pull our local numbers, clean them, validate them, send them up. But it's more than numbers. We join the discussions. National calls, working groups. Pharmacy voice matters. Look, adherence counseling doubles persistence on SGLT2 inhibitors. Discharge prescribing protocols lift ARNI use by 15%. Those insights shape the next round of measures, shape national benchmarks. Outcomes, national improvements, truly. When GWT-GHF reports show GDMT rates climbing year on year, when more patients leave hospital on all 4 pillars, that's because centers like ours contributed. One data point, one suggestion, one audit cycle, the needle moves. It's collaborative, no lone heroes, just teams sharing what works. Pharmacy input helps shape national quality. That feels rather special, doesn't it? Right, that's Activity 30, multi-center audits, GWT-GHF style. We're part of something bigger, and it matters. And there we have it, colleagues. The full spectrum of what makes a cardiology clinical pharmacist indispensable in our high acuity academic world. From bedside rounds to guideline development, from codes to clinics. We're the pharmacotherapy glue holding multidisciplinary teams together, saving lives, slashing readmissions, and pushing the boundaries with every new trial and update. If this series has sparked ideas, challenged your practice, or simply reminded you why we do this demanding but rewarding work, then hit that like button right now to show your support. Share it widely. Send it to your cardiology fellows, professor colleagues, pharmacy networks across continents. Let's get this expertise spreading like wildfire. Tap the notification bell so you never miss the next deep dive or update. Subscribe for more weekly educational gold like this, and drop a comment below. Which of these 30 activities has made the biggest difference in your own center? Or which one do you think needs more spotlight in 2026? Your thoughts, questions, and stories keep the conversation alive and help this content go properly viral. Thank you for joining me. Stay sharp, stay evidence-based, and I'll see you in the next video.